We'll now move to the BD Pimparkar Oration. I welcome the chairpersons for this session, Dr. Jay Bhatt, Dr. Kaushal Vyas, Dr. Smith Vagasia, Dr. Kailash Kolhe, and Dr. Ravindra Surude.
So good afternoon. Dr. B.D. Pimparkar sir, actually many of the newcomers would be not aware of him, but at least he was one of the most senior, most founders, I would say, of the GI department at KEM over here. He was one of the past presidents of ISG in 79-80. In fact, he was mentor to one of my mentors, Dr. Abraham sir. So in his memory, we have this oration, none to invite the distinguished personality like Dr. Patrick Kamath. Sir, please begin your lecture now.
Thank you so much. And Akash, thank you for inviting me and for your warm hospitality. I used to look up to Dr. Pimparkar, Dr. H.E. Desai, and Dr. Antya. They were my three gurus from Mumbai. Take this opportunity to acknowledge my mentors, Dr. Dilavri, who was here for some time, Dr. Rao, Harshad, my student from St. John's, and all my friends and colleagues from St. John's All India Institute, and Vijay, especially Dr. Nandi. So they are very much responsible for where I am today. So in this talk, I'll go over why we need prognostic scores. I'm going to keep this very simple. There are simple prognostic variables in cirrhosis which you should not forget. The current prognostic scores, and I was asked to talk on more than just scores. So I'll talk a little about research and how we got to the MELD score. And then finally, some take-home messages for life. So why do we need prognostic scores? So patients with chronic liver disease progress to compensated cirrhosis. Some of them will decompensate and become critically ill with extrahepatic organ failures, and they'll die in the absence of liver transplant. So patients move from what is potentially reversible to what is unlikely reversible. So we have to try and discuss with the patient and family what their risk of dying is, and that's the reason we require risk scores. Now, before we get into the actual scores, just a few basics here about how you determine accuracy of a model. We use discrimination. Discrimination tells you who is at the highest risk for mortality. It is measured by the C statistic, and you see if you get a C statistic of 0.8, it means 8 out of 10 times the person with the highest score will die before the patient with the lowest score. And this is very useful for population, so it's good for allocation systems. Calibration is when will the individual patient die? That is very difficult to determine, but hopefully in 2 years we'll come up with some answers. It is useful for the individual patient, it's good for counseling the patient. Patient can decide, I need to get my daughter married in the next few months because I'm unlikely to live a year. So it's useful for the individual patient. So let's go over just example. Discrimination is who's going to come first. So this is who will get the gold. This is London, 2012. So we know with discrimination models, very early in the course of the disease, it's not very accurate. As the disease progresses, accuracy increases. So here you can say, yes, I think Usain Bolt is likely to win. Accuracy increases a great deal closer to the endpoint, but remember, very close to the endpoint. So very close to death, any score that you have is actually describing the model. It's not predicting mortality. So here, no one is going to say, I predict Usain Bolt will win. They say he's won. So it's like you've got one ball left and 30 runs to score. You say we have lost. You don't say, I predict we will lose. Calibration is what is the individual time going to be. That's very hard to predict. None of the bookies predicted that the time was going to be 9.3 seconds, 9.63 seconds. That's very difficult. Not only is that important, you have to predict the time of each individual runner. So in the score, not only you say the country will win, you have to say what the score will be and who will score how much. That's very difficult. So calibration is difficult thus far. But like I said, hopefully in 2 years, we'll be coming out with something. The next thing to know about models is there are static models and dynamic models. Static is at a particular time point. So like the discriminant function, alcohol cirrhosis, alcohol-related hepatitis scores, MELD and ABIC. These are all at a single time point. Dynamic is predicting over time, and the best known is the Leeld score here. So, little more detail. So to summarize, why do we need prognostic scores? So we have a risk score, which we can use as a clinical tool most often. So we use it to counsel patients, we make management decisions, and that's how we try and optimize care. We use it as a research tool. It's entry criteria for studies. It may be an endpoint. A decrease in a certain score, that's an endpoint. Or you can stratify patients according to scores. So that is your research tool. And then it's a policy tool. So this is used for organ allocation. So these are the different ways you can use prognostic scores. Now let's take simple prognostic scores, prognostic variables in cirrhosis. I always do this at the bedtime. It's very simple. If the patient has compensated cirrhosis, the median survival is 12 years. I tell the patient, you have got some time, let's work on, some lifestyle changes, getting immunizations and everything up to date. If they've decompensated cirrhosis, that is ascites, overt encephalopathy or bleeding, median survival is dropping. So it's about 1.5 to 2 years. Let's get ready for transplantation. Further decompensation is a complication of a complication. You had ascites, now you've got recurrent ascites or acute kidney injury. You had a bleed, you have recurrent bleed. Encephalopathy, you have recurrent encephalopathy. If you're not a transplant candidate, we have to start making some end-of-life decisions here. So these are simple, broad classifications. One of the things to know is that endpoints are more predictable if progression is unidirectional. But now we know we can try and treat etiology, and this is likely to result in reversal of decompensation and regression of fibrosis. So I think in the future, accurate endpoint prediction is going to become even more difficult. Again, bedside. This is a very interesting study from Spain. Just look at mean arterial pressures. Those who had a mean arterial pressure less than 82, so that's a blood pressure of approximately 105/70, no one survived 4 years. Blood pressure was higher than 82 millimeters of mercury, mean arterial pressure, 50% survived. So just try simple things. So blood pressure can help you. So anytime we try and put together prognostic variables in cirrhosis, we look at biochemical dysfunction, portal hypertension, and extrahepatic organ systems. So portal hypertension, we have ascites encephalopathy, HVPG platelets, and sodium rather than renal, maybe it's part of the hemodynamic picture, the vasodilatation. Albumin, bilirubin, and INR, that reflects liver dysfunction. But now increasingly, we are going to have extrahepatic organ systems determine mortality. So not only just sarcopenia and frailty, it's going to be creatinine, coronary artery disease, renal failure. That is what's going to determine mortality in these patients. Now, if you try and put everything together, you can probably increase predictability a little, 0.1, 0.2. But then the model becomes very complex and it's difficult to apply widely. So, another rule, if you're trying to make a model, keep it very simple. So let's look at current prognostic scores. In decompensated cirrhosis, the prognostic scores are the CTP score, the MELD score and its variants. We've got organ failure scores. They're more reflective. They describe the dying process rather than predict mortality. And there are different scores for transplant, like the UCALD score for organ allocation, not widely used. So this is important. So ask yourself, there are 3 of these people who did great work, but no one knows they did really great work. Anyone knows who these are? Who did great work, but they're not recognized? Scream, shout. Okay. Now, there are 2 of these people who are disproportionately recognized for liver prognostic systems. Their names are on scores, but they didn't do much work here. Good, so you can see hands. So Mary Ann Payne, remarkable woman. You know, in 1961, there were not many women in surgery, not many investigators, and she probably did the best work here. So she and George Wants came up with what we now call the child score. I'll go over that. And then Roger Williams. And the ones who are disproportionately recognized, Pew, worked with Roger Williams, later went into tropical medicine and worked in Africa and the Middle East. And of course, Child, all the work was done by Jeremiah Turcott, who modified Wance's and Payne's model. But Charles Child was the big boss. He was a surgeon, and he got the credit for everything that was done. So these are the papers. Look at the paper by Wance and Payne, 1961, well before the Child score. Almost identical. This is what the Child score was: bilirubin, albumin, coma, ascites. And they recognized muscle wasting, which we now recognize is a problem. And then there's a Child Turcott Pew score. First author is Pew. This is the man who thought about it. And Roger Williams told me one of his big regrets is that he didn't put his name first here, because then it would have been called the Child Turcott Roger score, Roger Williams score. And this is how it's classified. So let's go back again. When you have a first diagnosis of liver disease, we don't have a score. We cannot prognosticate who's going to die. In compensated cirrhosis, again, we don't have a good prognostic score to say who is going to die, but we have 3 measures of who's likely to get decompensation. So the albumin, HVPG, and MELD score are predictive of hepatic decompensation. When we come into decompensated cirrhosis, it's much easier to predict. So MELD and CTP scores are predictive of mortality. And towards the very end, we use organ failure scores. But like I said, they're really not predictive of mortality. They're describing the dying process, and they're accurate when the disease is likely irreversible. So when you look at a patient with decompensated cirrhosis, the endpoint is death. And so the purpose of the scores is to predict mortality risk here. So how do we use the actual scores in predicting mortality? Again, very simple things. The scores 12 or greater and MELD score 21 or greater, that person's median survival is less than 6 months. Additionally, if they're hospitalized with a variceal bleed or SPP and the MELD score is 18 or greater, again, their median survival is less than 6 months. So you can use these to counsel patients. So to summarize, cirrhosis progression is no longer one-directional. Improvement in liver function and even regression of fibrosis is possible with treatment of etiology. And so current predictive models will become increasingly less accurate in the future, and reversal of cirrhosis, etiology, and death from non-hepatic complications are going to be what are going to impact the accuracy of models. So what we need is simple, cheap, AI-based models for more accurate prediction of endpoints in the future. So if you're going to use AI-guided prediction for prognosis, one, it has to be cheap and everyone should be able to use it. Once you get a complicated model, applicability is limited. There should be high acceptance rates, so you should be able to test it even in the patient's home. Wearable devices are attractive, but they tend to be expensive, so we don't want that. So the question we asked is, can we use ECG as a prognostic tool in cirrhosis. And this is the work that was in, our cardiologists had done work to use ECG to predict thing. So we said, can we use ECG to predict outcome in patients with cirrhosis? And most of the work was done by my fellow Joseph Ahn, who will join us back at the end of this year. So as a background, why did we use ECG? So there are profound circulatory alterations in cirrhosis. So we know hemodynamic circulation is critically related to clinical outcomes. And we have ECG abnormalities in cirrhosis. So prolonged QTc, QRS is low voltage, short TP to T intervals, from the peak of the T wave till the end of the T wave. So that gives you repolarization. All these are abnormal in cirrhosis. So we asked two questions. One is, can we tell whether a patient has cirrhosis or not just by looking at the ECG? So we developed this, what we call the ACE score. When we looked at about 5,000 patients, just looking at the ECG, 12 lead EKG for 10 seconds, 90% of the time we can say this patient has cirrhosis. Not only that, with this score, with a cutoff of 0.17 for diagnosis of cirrhosis, as the MELD score goes up, this score goes up and sort of peaks out at about 25. Now, if we follow these patients for transplant, the score keeps increasing, and then post-transplant. So post-transplant is here. You can see that. That's when they have transplant. The score comes down and normalizes. And 2 or 3 years post-transplant, it starts going up again for reasons we won't get into. So we said, okay, 90% of the time we can say there is cirrhosis. The question is, can it detect hepatic decompensation and predict liver-related outcomes? So if we take 0.25 and hepatic decompensation, the traditional markers, again, very accurate. At a higher score, we know these patients get decompensation. So unadjusted, which means you don't adjust for age, race, the drugs and all that they are, 4.28 odds ratio. But once you adjust for all of them, still contributes. So the ECG is still very helpful in predicting. So the question is, can we look at an ECG and say what's going to happen in 5 years to this patient? So we divided these into 0.25, it's not showing up too well, 0.5, so these quartiles, okay? So you can see here the mortality. So if we see an ECG and say the score is below 0.25, this patient will do well. We'll say 5 years from now, this patient is going to be alive. Depending on the score, mortality increases. And if the score is greater than 0.75, we say this patient is not going to be alive in 5 years' time. So just again, looking at the ECG. When we looked at outcomes, liver-related mortality was very good. You can see for liver transplant, it is not as good. MELD sodium is better, but we transplant based on MELD sodium. So that's why the ECG is going to be less accurate in here. But nothing is valid unless you externally validate it. So we work closely with the group in Barcelona. So they sent us about 500 EKGs. Did not perform as well as I had hoped in that model. So you can see accuracy, it's still predictable, it's still good, but not as accurate as we have developed. And that you'll see typically in AI-generated models. The machine has to keep learning, and we are working on that right now. So how do we use it in clinical practice? So this is our usual screen. If you pull this up, this tells us all the investigations the patient has. So if you look up here, in there, that's a chart review, and you go to cardiology, it'll tell you all the cardiology tests that were done. Then we click on the AI dashboard, and this comes up for our patients. So we can say, probability of low ejection fraction, hypertrophic cardiomyopathy, silent atrial fibrillation, all low. Okay, so this is a patient who's normal, low probability of cirrhosis. Let's take some real life examples here. So patient admitted with ACLF, you can see the score has bumped here. And so probability of cirrhosis has increased, and we know at that score that patient is critically ill. So this tells us immediately, so the moment the readout comes, we know how the patient is going to be doing. This is a patient, 70 years old, was very interested. MASH cirrhosis, MELD score is only 10, but her ECG score was really high. And she actually had refractory ascites, SPP. Everything else seemed to suggest she was sick, but the MELD score was low. So this helped us here because the A score picked up disease severity, which the MELD score did not. Post-liver transplant, young woman with PBC, look at the high score before transplant, post-transplant comes back to normal. So to summarize, ECG-based model can predict presence of cirrhosis on ECG with impressive performance metrics. It may predict liver disease severity and complications and mortality over time. And the next steps are additional external validation, prospective validation, explainability studies, and correlation with echocardiography. And when Joseph Hahn comes back to us later this year, we are trying to work on what is called synthetic data sets, and hopefully at some time outside I can go over how exactly it's done. We'll try and predict mortality in the individual patient, not in the group of patients. So I think that's the next step ahead, but I think it may be a couple of years before we can give you those answers. Now, Akash asked me to talk on more than just scores. So the question is, how did we come up with MELD and how do we get research ideas? So fellows will come to me and say, give me research ideas. So I asked them, who do you think is the best person to give you research ideas? It's not me. The best person is a patient you're looking after. They gave you research ideas. If you want to try and do something better, you don't know the diagnosis, work on better diagnosis. You don't know the treatment, work on better treatment for the patient. So the patient is the one who gives you the best research ideas. So I joined Mayo in 1991. We started doing TIPS 1992. January 9th was the first TIPS that we did. We found some patients died. I remember this woman extremely well, 53 years old from the neighboring state. She had lost her husband the previous year. The son was with us. They had only one son, and so they're all very anxious. They've lost their father. She asked me, what is the chance of dying? I said, no, I think you'll do well. And unfortunately, she died 2 months later. So I said, okay, whatever tools we have so far are not good in predicting mortality. We have to actually do better. So that's when we started working on the MELD model. So we had a question. So if your question is very simple, then research becomes much easier. And this is a question that clinicians wanted an answer to. And I had collaborators, and of course I must acknowledge my former fellow, colleague, and now in effect is actually my mentor, Ray Kim, who helped in developing MELD and taking this forward. There's another message I want to give you here. Don't give up, okay? All of you, I've had lots of papers rejected, so never give up. So I wrote the paper, I went to my mentor, Sid Phillips, who looked at it, he said, hey, this is a new technique, you found a way to predict who will die, send it to New England Journal of Medicine. Sent it, 1 week later, came back, reject without review. They said, I think it's a really important question, but all these modeling and math is too complicated for our general readership, so we are not interested. I said, okay, I agree. So we sent it to Gastroenterology, came back within 1 week with exactly the opposite comment. They said, your statistics and math is great. We are really very impressed, but we really don't know why you did this study, because mortality is not important in TIPS, because you should use only TIPS pre-transplant. I said, okay, maybe difference of opinion. Sent it to Hepatology, rejected. Very curt comment from the editor, who later apologized to me. He said, you really think creatinine will predict long-term outcome? He said, because HCC kills patients, not creatinine. I said, okay. we realized that no one believed that you can predict outcomes 2 years ahead. So we said, okay, let's make it 3 months. That's the median time for till you're on the waiting list for transplant. And so let's just make it a 3-month model. So I rewrote the whole paper. I got figures different. I put an algorithm and I revised it and sent it to Hepatology as a new paper. And then it was accepted finally after 2 revisions. So don't give up on an idea. Your paper will find a home somewhere. And as a result of that, because we persisted, now we can use it as a metric for severity of liver disease. It's used for organ allocation worldwide. You can stratify risk for alcohol-related hepatitis, selection for surgery or for TIPS, acute liver failure mortality risk, especially with acetaminophen, and variceal bleed mortality risk. And finally, some take-home messages for life. And this, I'd like to remember Dr. Pimparkar too. So I think I'm old enough to give you some advice, okay, all of you. So one, unless you remain healthy, you cannot make others healthy. So eat healthy, exercise regularly, don't smoke, minimal alcohol. Dream big. Do not let your dreams die, because if you let your dreams die, you cannot progress. And the only one who can make your dreams die is you. So never let your dreams die. Never stop learning. Always be curious. I used to see Dr. Pimparkar at meetings taking notes. So never stop learning. Always be curious. Put service to patients before self. The reason we have a job is because of patients. If there were no patients, we would not have a job. We would have no career. So always put service to patients before self. And then finally, be honest. Always be honest. Be humble, be helpful, and always be kind. Remember, these are the characteristics of good human beings, but I think they'll also make you a better doctor. Thank you.
Thank you, sir, for your words of wisdom. And since it's an oration, we do not have questions. Thank you, sir.
Thank you, Professor Kamath, for the oration. I request the chairpersons to come forward and felicitate Professor Kamath. Thank you, everyone.